We've made it to the actual procedure itself. If you're looking at those procedure guides, again, that are on Blackboard, it goes through checking your equipment, doing a complete history. That's going to include Mallampati scores, all of that. All of that stuff is exactly the same as you would any other anesthetic, all right? Once you get to this point, I'm going to go through just the procedure itself. I'm not going to go over, you would inform the patient, obviously, of risks, benefits, that sort of thing. I'm not going to go into all of that today because those are things that you're going to cover in your regional course. What I am going to do is show you the actual procedure itself, all right? So like we talked about, this is our mannequin here. I'm going to feel for iliac crest, and on these mannequins, you can feel them. It's right here. So I want to feel across from that, and I can feel right in there spinous process, or a bump that I'm calling spinous process, right? Because I can feel the top of the hip here, top of the iliac crest, and I can feel a bump right there. That is L4 spinous process. Tufier's line, L4 spinous process right there. When you find this on a patient, and again, this is with a patient sitting up because that helps align the spine and the hips and make it easier on you. Both of these blocks can be done with the patient in the lateral position. It just increases the complexity of the block, all right? So again, I'm feeling here, Tufier's line, L4 spinous process. Once I find that on a patient, I need to go ahead and make a mark, because once I prep and everything, I want to know exactly where that mark is. So that's where I'll know to make my skin local to begin my actual procedure itself. Some people will use their fingernail to push in and make a mark right there on the back. You can do that. I don't have much luck with that in my fingernail, so I usually take my ballpoint pen. It's a retractable pen. Make sure the ink is retracted, obviously. But then I'll take that pen and I'll just push it in right there, and it'll make a small circle right on their skin, about like that, and that ends up being a bullseye. It'll last a good 5 or 10 minutes, so all through the prepping process and everything, it's going to last, it's going to be there, all right? So I'm going to feel for that. That's where it is. Go in, make my mark, and again, I suggest you're talking to the patient this whole time, all right? I usually tell them, don't worry, I'm going to tell you everything I do before I do it. Not going to be any surprises. And then you're going to verbalize out loud. I'm about to push on your back. You're going to feel me, feeling of your hips. When you get ready to do the local, I'm going to give you a big numbing shot. It's going to feel like a bee sting. You're going to feel a prick and then a burn for about 20 or 30 seconds. So you're telling the patient everything, right? So you're helping kind of appease anxiety and let them know what's coming. So I've identified L4 spinous process. On this mannequin, it's right here. So I'm feeling the inner space. I can feel another bump here. So that's the L5 spinous process. This bump here is L4. So I'm going to go in this inner space right here. And I'm going to make a mark just above that L5 spinous process. So just above the inferior spinous process, I'm going to make my mark. Then I'm going to go ahead and prep the patient. Most of the kits that we have here, and most of the ones that you'll see in the hospital nowadays, still have betadine in the kits, because last I checked, ChloraPrep was still not FDA approved for neuraxial blocks, because when wet, ChloraPrep can be neurotoxic. Funny thing about that is betadine that comes in your kits, also neurotoxic when wet. Chlorhexidine or ChloraPrep is a superior cleaning agent. There's tons of literature out there that supports that. There's also a ton of literature out there that supports the safe use of ChloraPrep for neuraxial blocks, as long as you allow a proper dry time between application and actually going in with your either spinal needle or epidural needle. That dry time, length of time, is 3 minutes. All right, same as it is in the operating room. So that's pretty quick. It actually dries quicker than the betadine, so it's easier to use from that standpoint. And so most of the time, we'll make our mark, open up our ChloraPrep, prep the back. You're going to prep this whole thing. You're going to scrub it wide, right? So you want to be able to have enough room to where if you can't get in here, you want to have enough room to where you have 2 or 3 inner space levels prepped, right? And it needs to be wide enough to where if you can't get in, you can go in midline, or excuse me, paramedian, all without having to re-prep the patient, right? So you want to prep an area that's nice and wide so that you can kind of adjust your game plan once you get in there if you need to. So I'm going to prep that whole area, toss this aside. Here's my kit. I'm hoping you guys can see it up there. I'm going to open this thing up just like I would with anything. I'm going to open it up facing away from me. All right, that's part of proper sterile technique. Once I've got it open, I am going to put on sterile gloves. I'm going to put on a mask and a hat. For most institutions, that is what's required for epidurals and spinal blocks. Sterile gloves, mask, hat. Okay? So I've got all of those on. I'm not actually going to put them on here, but I would put them on in clinical practice. I'm going to look into my kit. So what you'll see here is some betadine. We don't really use that anymore, but that again comes in the kit. I'm just going to toss it off to the side. A little prep tray that is designed to be used with the betadine. Again, we don't really use that anymore, so what I'm going to do is take these sponges out of here, toss them out. I'm going to keep this gauze because I'll need that, and put the little prep tray there. Next thing I want is my drape. And so this will say a fenestrated drape, and it'll have one of these in there, and it'll be either solid. The kits we have at work now are clear so that you can see the rest of the back as well. But fenestrated is what you're looking for. And so basically fenestrated, they may give you two drapes is what I'm getting at. Fenestrated means it has a hole in it, right? And you're gonna put that hole over the area that you just cleaned here. So I'm doing this sitting down, but you would be doing it standing up, which means you would raise the bed way up in the air. The reason I'm doing it sitting down is because it's easier to film this way. But in clinical practice, you would be doing this standing up. And the reason for that is that it makes it easier to not contaminate things. So I'm going to open this drape way up high in the air. Now here, it's touching this table because I'm sitting. If I was standing, I'd be opening it up way back here and then bringing it in and putting it on the patient here. You can peel this off. That's adhesive under there that'll stick to the patient. So I'm going to open this up. I'm going to put the hole right over the area that I prepped and marked. Right? So now I have the back draped. And you can see just the area that we're going to work. They give you this extra one. If you need it, you can put it down here to extend your surgical field out. I don't think we'll need that today, so I'm going to put it right over there. Looking in my kit, I have some labels for the epidural catheter that I'm going to put in. Anytime you put in an epidural catheter, always label it. You know, people say, well, I don't have to label it. The epidural or the OB nurses know what an epidural is. They absolutely do. They've seen hundreds and hundreds of them. But that first semester nursing student that's going to come in the morning and take care of this patient has probably never seen one before. And here in a minute when we're done, I'm going to put an adapter on this catheter that has a lure lock so that we can put medication through here. And without one of these stickers on here, they can put anything they want through that lure lock. They can do that even with the sticker on there, obviously, but at least then you've done everything you can to label this thing appropriately and reduce the chance of error. So always put that thing on there. I'm going to keep it and just kind of set it right there for now. Looking in my kit, I'm going to move this over here so you can hopefully see it a little bit better. If I'm looking in this kit, they're going to give me an assortment of local anesthetics and some saline here. This is my epidural catheter that I'll need. This is my TUI needle, which we'll need here in a minute. A couple of syringes. This one is actually a combined spinal and epidural kit, so they gave us a spinal needle right there as well. A little filter to put on the catheter when we're done. Glass syringe. This is your loss of resistance syringe. We'll talk about that in a second. And then a couple of syringes that you can use for the spinal portion of this. When we look in here again, they give us saline, which is good to have. Regular 1% lidocaine, so I'll flip that around so you can read it. 1% lidocaine. We're going to use that for our skin wheel to numb up the skin. And then they're going to give us 1.5% lidocaine with epi 1 to 200,000. If you remember back it's been a while, but back on the drug lecture day, This is the test dose that I was having you guys make, you know, with your mathematics. This is what we're going to use for a test dose here in a minute to test the location of this catheter. So this local anesthetic, the blue one, is what we need first. As a general rule, when you're looking at local, anything that has red writing on it typically means it has epinephrine in it. We want to save that for the test dose. So we're going to open this one first, okay? So I'm going to set this kit down here. I'm going to open this up, and because we're in lab, I'm not going to necessarily open it, but I would crack the top on that. Give you a filter straw because these are glass vials. I'm going to put that down in there, aspirate out 3 cc's into this syringe, and then they gave us an assortment of needles here, right? So we've got a 22 and a 25. I'm going to take the 25 because it's a little bit smaller and gentler on the patient. Now I'm going to feel back here on the back again. So we've done all of this stuff in that 3-minute time. So our ChloraPrep should be safely dry and ready for us to stick the skin. So I'm feeling right where I made that mark, and I'm going to warn the patient, okay, this is the part where you're going to feel that bee sting. It's going to be a big stick and then a burn here in your back. I'm going to go in right where I made that mark with the bevel facing up, and I'm going to go just under the dermis and give about 1/4 cc. And they're going to get a whelp on their back like a TB skin test, right? So you're going to do an intradermal injection first. And again, not much, 1/4 cc. That's all it takes to make a whelp about the size of a dime. And that's important because most of the pain afferent nerve endings are right there in the skin, right? So if you get a real good skin whelp, you can then go in and they'll feel it as you inject. But when you go in with this big TUI needle here in a minute, they won't feel that stick. If you go all the way under the skin into the sub-Q, you'll numb up that sub-Q great. And when you stick them with the TUI needle, they'll feel that big thing going through their skin, right? So make a little skin wheel. Once you're done, again, we're going to try to go midline. So I'm going to go all the way in and inject about 1/2 cc on the way out. Then I'm going to come here, go all the way in, inject another 1/2 cc on the way out. I'm going to come here, go all the way in, inject another 1/2 cc on the way out. I'm going to go up, inject 1/2 cc on the way out, go down, inject 1/2 cc on the way out, and that should use up pretty much my entire syringe. So what I've done is I've numbed up an area about the size of a golf ball underneath their skin. So I have room to adjust my needle around, and they shouldn't feel any of that needle sticking or poking or anything like that that's going on. I come back with my TUI needle, which is this thing right here. All right, they come in different sizes and that sort of thing. The standard TUI needle that you're going to find in your kit is 9 centimeters from these plastic wings to the tip. Right? And you can see that they have alternating light and dark markings. Those are the centimeter markings on your needle. So when I was telling you if you're hitting bone shallow, 3-4 centimeters, and you have to adjust up and down, and if you were thinking, how in the world do I know if I'm 3 or 4 centimeters? Because they're marked right here. Right? So it's important to know a few measurements on this thing. It is 9 centimeters from the tip of this needle to these wings. Right? Right here in this hub, there's a little window that you can see through, and that'll be important in a minute when we get to ready to put our epidural catheter on. But it's 10 centimeters from the end of this needle to this hub. When we get ready to put the catheter on, there's a catheter guide that goes right inside the end of this hub. It is 12 centimeters from the tip of this to the end of that guide. Those are important measurements, again, to know. So 9 centimeters from here to here, 10 centimeters from here to here, and 12 centimeters from here to the end of the catheter guide that we'll put on here in a minute. All right? The reason that's important to know, when I got this buried in somebody's back like this, right? Let's say I hit epidural space. I want typically 5 centimeters in the epidural space, 5 centimeters of catheter in the epidural space. How do I know if I get 5 centimeters in there? Well, I'm going to count 1, 2, 3, 4. I've got 4 centimeters of needle sticking out of this patient's back. I know that it's 9 centimeters from here to the end. So if I have 1, 2, 3, 4 sticking out, that means it must be 5 centimeters from their skin to the epidural space. If I want 5 centimeters in the space, that's going to be a total of 10 centimeters of catheter. So it takes 5 centimeters just to get to the space and the other 5 in the. When I get done threading the catheter and taking this thing out, I want that 10 centimeter mark right there on their skin. Right? And I know that because I know the measurements on this needle and I can count them off that way. All right? So let's show you what this looks like. Oh, one other thing before I forget. Your loss of resistance syringe. Oops, I just dropped mine. Typically they're glass, right? This plunger does not have any kind of rubber plunger thing on it because that would cause resistance. And the idea behind this is that there should be little to basically no resistance on it. They do make a plastic version of this that some kits will have, but typically what comes in your kit is a glass syringe. When you pick this thing up, this is specifically for loss of resistance technique, so that's why they put this in there, right? You're going to use that with the TUI. When you pick this thing up, pick it up like this, right? Because again, there's no plunger or there's no rubber on that plunger. If you pick it up out of the kit like this thing will fall right out, right? Smash onto the floor in 1,000 pieces, and then you look really bad. Like we've said before, there's going to be plenty of opportunity for you to look like an idiot. We want to decrease the odds of that happening, right? So when you pick it up with this lower part pointing down, right? That way this thing doesn't fall off on the floor and you kind of look like you know what you're doing, right? So we need this and this, and probably we're going to need one of these 4x4s because they're going to be bleeding a little bit from where you stuck them, so you can just kind of dab that bleeding and get it out of your way. TUI needle. Here we go. It's got a stylet that goes right down through here because the tip of that TUI needle is pretty big. It's got to be big enough for this epidural catheter to go through. A lot of kits will have a 16 gauge TUI needle in them. What that means is that tip, that bevel right there is so big that without this stylet in, when you put it through the skin, you'll get skin or sub-Q tissue that will get in that hole and plug it up. And so then you'll never know when you're in the epidural space because you'll always have resistance on this needle. So when you're going through skin and sub-Q tissue, it's important to have this stylet in the entire time. Once this needle gets into ligament, you can safely remove this stylet, put your syringe on there and use your loss of resistance technique. Because the ligament is so dense that it will be pushed out of the way by this rather than actually coming down and entering into the lumen of this needle. So I say when you're in ligament, you can take the stylet out. How do you know when you're in ligament? Glad you asked. When you put this thing through, this is a pretty big, pretty heavy needle as far as hypodermic needles go. When you're in skin and sub-Q, if you have any doubt about it, just take your hand off the needle. Do you see how it sags down like that, like it's trying to pull out and land on the floor? That means that I'm in skin and sub-Q. Again, the ligament is so dense that once you get into the ligament itself, you'll feel a change in the resistance on this when you're pushing it in. But also, when you take your hands off, it'll stand straight out of their back, right? It's not sagging down to the floor, it's standing straight out. When it's doing that, that's an excellent sign that I'm in ligament. So then I can take my stylet out and use my loss of resistance technique. All right, so we've been all over that. I want to feel here again just to know my landmarks. So there's my L5 spinous process. I'm going to come in just above that. I'm going to seat this until I feel like I'm in ligament, which I feel like I am right there. Take my hands off it, standing out. I can pull my stylet out. I'm now going to grab my loss of resistance syringe. I'm going to pull it back, screw it onto the end of this, and now I'm going to advance this needle with this hand. I'm right-handed. So I'm going to advance with my left hand and I'm going to push on this plunger. I don't know if you can see me pushing on this plunger like that. I'm going to push on it with my right hand. There's resistance on this because the ligament is so dense I can't push air into that ligament. So I'm going to push on this plunger and when I take my thumb off it bounces back. I push on it and it bounces back. That's the resistance that I'm feeling, and that's what I'm looking for right there, right? When I hit epidural space, so it's going to feel like that. It's going to be very bouncy, bouncy, bouncy. When I hit epidural space, it's going to do that and not come back. Or if it does, it'll just barely come back. That's going to let you know that I have now lost resistance. So when I'm in here, this is what resistance looks like. I push on it and it bounces back. Loss of resistance, no bounce back, right? Okay. The other thing I recommend, some people will push, check, push, check, push, check. That can be kind of risky because you could be in ligamentum flavum, you advance 3 millimeters, you're now all the way through the epidural space into the subarachnoid space. So the way I was taught and the way I recommend is once you're in ligament, so we're going to say that I'm in ligament right there. I'm going to put my loss of resistance syringe on. And I'm going to put my hand right here, right? So I'm stabilizing this hand against the patient's back. I'm gripping the needle, and I've got about 1.5 centimeters worth of needle between them and my hand. And I'm going to work until I run out of needle, right? So then I'm going to come back and I'm going to work some more. And what that does is if the patient moves, I can control how much needle goes into their back at one time. If I'm way out here and the patient has a contraction and moves, whoop, there's a whole lot that could go in there at one time, right? So I'm going to control what I can control. So I'm going to put my hand right here. I'm going to go in and I'm just slowly advancing until I feel that loss of resistance. And there it is, right? Once I've lost that resistance, I'm going to take this out and I'm going to look. I can let go of that needle. Again, it's that ligament's holding it in place. It's not going anywhere. The first thing I'm looking for is any kind of liquid that comes out of this. I didn't put any liquid in there, right? So if anything wet comes out, if it's red, guess what? It's blood. If it's clear, it's spinal fluid and you've gone too far. So if that happens, you just take this needle out, go up a level, go back in and try again. Or the anesthesia provider that you're working with shows you out of the way and they do it. So we're going to assume that you found epidural space. Everything is good. I'm going to come and grab this catheter that's right here. And I'm going to take it out. So I'm going to show you a couple of things. Here's the little adapter that we're going to put on it at the end in order to push through it. This little pink thing right here, this is the catheter guide I was telling you about. And so once it's in the hub, it's 12 centimeters from that needle to here. Why is that important? Because this thing has markings on it. They start at 5 centimeters. It goes all the way up to 10, which is this double bar right here. 15 is the triple bar. 20 is the 4 bar. They have a big wide bar, and these markings are universal this way. They'll have a big wide bar. Sometimes they're in blue, sometimes they're in black, whatever. But they'll have a big wide mark right there at 12 centimeters, right? And so that's to let me know once I get this thing in here, I'm at 12 centimeters. If I advance past that, I know that at 12 centimeters, the catheter is coming out of the needle. That's important because once the catheter leaves the needle, you cannot pull it back through here. If I get to here and I can't advance the catheter and I say, oh, maybe I'm not in the epidural space, it hasn't gone past the tip of the needle, and I know that because of this, I can safely pull it back. If I advance it past the needle and then pull it back, this is what happens, right? So I'm at 12, I advance a little bit further. You can see how that thing comes out past the needle. And what happens when it's in the epidural space is it goes up the back like this. I'm going to turn it sideways so you can see that right there. So it goes up like this, right? Once it does that, let's say I hit an obstruction and I can't feed anything more. When I pull back, this is a cutting needle, right? Just like any other hypodermic needle. When I pull back on, it will cut that catheter off and leave part of it in the patient's back, and the rest of it will come back through the 2E needle. You don't want to leave any catheter broke off in somebody's epidural space, right? So that's why if you get to right here and you can't advance any further, you grab the needle and everything, take everything out. Once you're out of the patient, this thing can relax down. You can pull it back through, go right back in and find that epidural space again, all right? Never pull back the catheter once it's left the tip of the needle, all right? The way you can know that on all of these catheters, whether these markings are blue or black, it's going to have one of those markings right at the very tip of this catheter, right? If you pull it out of somebody's back and the tip looks like this without any mark, some of it is left inside. When you pull it back, the one thing you're going to document every single time you remove an epidural catheter is that the tip was intact, and you're going to know the tip is intact because of that dark mark right there, okay? All right. So I'm going to go back in and find my epidural space again. So just like before, I'm putting this on here, controlling what I can control, and I'm in. And I've got 1, 2, 3, 4, 5 centimeters sticking out. All right, if I have any doubt about it, I can try it again. Doesn't come back. Oops, don't do that. All right, I'm gonna take my catheter guide. Goes on the end. Epidural needle, or excuse me, epidural catheter through the needle. I get to the 12 centimeter mark right here. If I can advance, and I can, I advance this catheter on into the patient's back. All right? Again, I know that I'm in there because that 12 centimeter mark, this is what I can see. It goes past the end of the catheter guide, which tells me that it's out right here, okay? So one more time, let me show you what that looks like. Glass syringe goes on here. Lost resistance. Catheter guide is on. I'm threading. I'm at 12 centimeters. I'm threading the catheter. Let's see if it'll thread. And this one doesn't seem to want to thread. So that's fine. I could hit a false loss of resistance, and that does happen sometimes on people. It happens on these mannequins for sure, because you just hit an air pocket that someone else has made in the past. I know that I can't thread because that big mark won't go past that epidural catheter guide. So I can take this safely out because it never went past the tip of the needle. When this happens to me in clinical practice, what I do is I pull this needle back a little bit and I work my way right back in and see if I can lose resistance. And I lost resistance right there. I look like I'm about 1/2 centimeter further in than I was before. Put that catheter guide on. Let's see if it'll thread this time. And it is threading. I don't know if you guys can see that. But the catheter is threading through the needle. There's the window I was telling you about. And you can count that catheter as it goes in. You can see the triple bar right there. That's the 15 mark. You always want to go past the 15. You don't have to go all the way to the 20. But you want to go somewhere in between. All right? So I want 5 centimeters in the epidural space. I have 1, 2, 3.5 sticking out. I know that it is 9 centimeters from there to here. I have 3.5 centimeters sticking out. That means it must be 5.5 centimeters to the patient's epidural space. If I want 5 centimeters in the space, 5 plus 5.5 is 10.5. So I need about the 11 centimeter mark right there at the skin. I want to hold this catheter in place, and I'm going to try to push it, but once the tip of this needle comes back out of the epidural space, I won't be able to advance it. I'm basically just keeping myself from pulling the catheter out with the needle when I take the needle out. So I'm going to push on this in slightly, and I'm going to take this needle and pull it out backwards. Okay? Once I've got it out of the back, I can just grab it and pull it through the needle like so. Again, we said we wanted the 11 centimeter mark at the skin, so I don't know if you guys can see, but there's the 15 centimeter mark right there. There's 14, 13, there's my big wide 12 centimeter mark, 11. I'm going to leave it right there. 11 centimeter mark at the skin, that's telling me that I have 5, in this case 5.5 centimeters in the space. Find the end of this, and I'm going to put my adapter on here, and it just goes right through that little hole at the end. Just push it till it can't push in anymore, and then twist it down so it locks. When I do that, I take this cap off, and now I have a lure lock, and I can push medication through this catheter. First thing I want to do is put a syringe, an empty syringe on here, and pull back, right? When I pull back on this, what I'm looking for is if I get blood or CSF in this catheter, because I know where the tip of this needle was, but I can't control this catheter once it leaves the epidural needle, right? So it could thread itself into a vein. It could go into the subarachnoid space. They've been known to do both of those things. So I'm going to pull back, and if I get any fluid, if I get CSF or blood back in here, I know I'm in the wrong spot. I'm going to pull this catheter all the way out. I'm going to go up a space and put it back in again. But I'm going to pull, and hopefully I get nothing back in return. And that's good. So I'm going to take that. I'm going to put my little filter straw back on here. And now I'm going to grab my test dose, my lidocaine with epi, 1 to 200,000. I'm going to do that, crack the top. I'm pulling up 3 cc's of this, just like we talked about in that math lecture that day. And I'm going to push this through the epidural catheter. So I've got 3 cc's of 1.5% lidocaine with epi, 1 to 200,000. That is 45 milligrams of lidocaine in here and 15 mics of epi. Why is that important? Why are we giving this? Again, this was in the epidural space. We're pretty confident. We're pretty confident that this is in the epidural space, but that's also a very small catheter. So what happens if it got into a blood vessel and just got a little clot on the end, and I aspirated on it and got nothing out? Well, I don't want to put a ton of Marcaine or some other cardiotoxic drug into someone's vascular system, right? It's fine in an epidural space, but not necessarily in a vein. So I'm going to push this in. Typically, these things are in one of 3 places, right? They're either in the epidural space, which is what we're hoping for, they're in the subarachnoid space, or they're in a blood vessel. When I push this in, and you're just going to push it in rapidly like that, there's enough lidocaine in here, that 45 milligrams. If this catheter is in the subarachnoid space, they will get a saddle block. And a saddle block is basically on the inside of the leg from one knee up around the perineal area and down to the other knee. That will get profoundly numb. They'll get numb in their butt, and it'll be difficult for them to pick their knees up off the bed. If that happens, and it'll happen rather quickly, within 2 minutes, if that happens after I push this, I know this thing is in the subarachnoid space. I'm not pushing anything else through it. I'm taking it out, I'm going up a level, and I'm replacing it. Right? If I'm in a blood vessel, I push this. That lidocaine is no big deal, right? We give people way more than that when we induce them for general anesthesia. So 45 milligrams of lidocaine, no big deal. But there's 15 mics of epi in here, and that's what we're looking for if we're in a blood vessel. I push this in there. Most of the time, you're going to want to tell the OB nurse or whoever's with you to put a pulse oximeter on the patient. You push this, and you're listening and looking at their heart rate. If their heart rate spikes up, lasts for about 10 seconds and drops right back down to normal, That's your 15 mics of epi hitting the heart, right? And it's profound. It's not like, oh, their heart rate's 80 and it goes up to 92. No, that's not what you're looking for. That could be a contraction pain, right? If it's 80 and then it shoots up to 130 last 10 seconds and drops right back down to normal, that's a positive test dose. That lets me know that this thing is in a blood vessel. Again, we don't want to leave it there, so we would take it out, we'd go up a level, put it right back in again. What we're hoping for is a negative test dose. We push this in, none of those things happen, which means this thing is in the epidural space and there's not enough lidocaine or epi in here to do anything to them in an epidural space. So we hope that we push this in. The patient says they are fine, they can pick their knees up off the bed, their heart rate's not racing, anything like that. That lets us know we're in the epidural space and we're ready to go. If that's the case, we take this little sponge that has a cut in it that goes about halfway through the sponge. This sponge goes on the skin and this catheter comes up, runs right through that little sliced area, up over the patient's shoulder. You can then rip this drape off, put tegaderm and everything on top of it. The purpose of this sponge is it allows a little bit of cushion. When that patient lays down, it keeps this catheter from getting kinked off at the skin. All right? Once you tape it in place, lay them down, then you can give them whatever medication through there that you need to for your facility. So let me show you one difference between an epidural and a spinal. The identifying the landmarks, the prepping, the draping, the localizing, all of that exactly the same. When you get ready to do a spinal, you're going to typically use one of two needles, either a 22 gauge cutting needle, like this one right here, which is what we use if we're putting these in for a TURP or a total knee or something like that. If that's the case, it's totally fine. You just insert the needle. The cutting edge of this needle is up like this when you go through the skin. Once you get through the skin, you rotate it 90 degrees. So now that cutting edge, instead of being up, is turned sideways like this. And the reason for that is your dural fibers run longitudinally from the head down to the sacrum, right? If I have my cutting edge on this hypodermic needle up like this, when I poke through the dura, I'm going to slice through those dural fibers and I can leave a flap that can then open and they can leak CSF out and get a post-dural puncture headache. All right? So I'm going to turn the bevel 90 degrees. So instead of being up, it's turned like this. So now when it goes through, it's in the same plane as those dural fibers. And as it goes through that dura, it's more likely to just kind of push them out of the way. It may cut 1, 2, but that's about it, right? So I'm going to put this in. I'm going to turn it 90 degrees. And with a spinal, there's no loss of resistance, nothing like that. It has a stylet, just like an epidural needle. I'm going to leave that stylet in the entire time because it gives it a little bit more tensile strength. And I'm going to push this in. And once I get about halfway in, I'm going to take this stylet out. And I'm going to see if any CSF comes out. And if it doesn't, I'm going to put that back in. And I'm going to advance about another centimeter. And I'm going to stop and pull that stylet out. If nothing comes out, that stylet's going right back in. And I'm advancing another centimeter. And you're just going to keep doing this over and over. And your goal is, when you enter that dura, you'll feel a pop most of the time with this. And then when you pull that stylet out, CSF will start dripping out. So I'm going to keep going. And the CSF dripping out part can be a bit hit or miss sometimes. I just felt a pop right there with these mannequins. It can be hit or miss. And so let's see. And so I don't know if you can see that, but I've got CSF dripping out of this needle, right? Once I have that, I'm going to take this syringe that I've got my medication drawn up in. I'm going to put it right in here, and I'm going to aspirate back. And what I'm looking for is a swirl, what we call a swirl. I'm going to put this in just so we don't drip all over the place while we talk. When I put this in there and aspirate back, I'm going to look for a swirl. And what that swirl is the specific gravity of CSF is different than the local anesthetic that you have in here. And so you'll see a little swirl of that CSF as it enters into this syringe. And the best way I can describe that is if you've ever given Ativan to crazy people in the ICU, you know, that had to be sedated, maybe they were on the vent or whatever, you know, that Ativan is a very oily drug. And so if you had a syringe with some saline in it and you pulled that Ativan up in there, you could see that oily swirl of it as it entered the syringe. That's what CSF looks like when it enters here. So I'm going to put this on. I'm going to aspirate. If I get the swirl, great. I'm going to inject all my medication through here. I recommend aspirating again at the end to get that swirl, injecting everything through. And then you're going to grab right here and pull everything out all at once. So that's with a 22 gauge. The other one that you'll likely use is a 25 gauge pencil point needle, like this one right here. So a pencil point needle is different than a hypodermic needle. It's rounded at the end and slightly blunt. And then the hole for that, instead of being at the end where the bevel is, it's about 1/2 centimeter back from the end. And what that does is when it goes through those dural fibers, it's blunted and completely round, so it shoves those fibers out of the way. You deposit your medication, pull it back, and the fibers close behind it. And it greatly cuts down the chances of you getting a post-dural puncture headache. We recommend at our facility using these on all parturients, right? So any C-section that you do, you're going to do a 25 because those patients are typically at a higher risk for post-dural puncture headache. One thing to keep in mind, I don't know if you can see, but these 25s are unbelievably flimsy because they're 3.5 inches long, right? And so a lot of times when you try to push it in skin, it'll bend up like this, especially when it gets to ligament, and it can be very difficult to advance. So you want to take some sort of introducer, and most of the time that's a 25 gauge. So you can take just a 22 gauge needle that comes in your kit, and you can use that as your introducer to push right. And that adds some stiffness to it so it doesn't get bent up as it's entering the skin, and it allows it to travel in a straight line right through the ligament without bending as well. And I'm running into this, there we go. So same thing, I'm going to advance this, I'm going to check, I'll put that back in, I'm going to advance, I'm going to check, nothing's coming out. Stylet goes back in. Keep advancing. I felt a pop right there. I'll pull this out. And now I don't know if you can see it again, but I have CSF coming back through the hub of my needle, dripping down onto my hand right there. I would put this on, aspirate, inject, aspirate, inject. At the end, everything comes out all at once. Okay? One other thing to keep in mind, when you're using an introducer, it's a cutting needle like any other hypodermic needle. And so what can happen is that this can come through here, and let's say you're entering and you hit an obstruction. And you can't really tell because it's a 25, and you push a little bit harder and you can bend that needle like that, right? Well, if you pull back, now there's resistance on that. And I'm telling you, these 25s are unbelievably flimsy. And so what can happen is if you pull it back through here, this cutting needle of the introducer can cut that spinal needle off, and now you're left with spinal needle in someone's back. And if you don't believe it can happen, ask Rusty, because it happened to him about 1 week out of school. He was a CRNA for about a week. He was working with a student. They did that, and boom, left epidural, left spinal needle in someone's back. As you can imagine, that becomes a neurosurgical case rather quickly, and can be quite problematic. All right? So if that happens, if you're going through here and you hit an obstruction and you can't advance any further, what you're going to want to do is pull everything out all at the same time. So you go in, you hit an obstruction and it bends, right? It's in someone's back. You're going to grab the introducer and everything, pull everything out all at once. Once it's out of the body, you can straighten this thing out, pull it out. If the bend is pretty benign and it's salvageable, you can put the stylet right back in. If it's bent up bad and you can't get it straight, you just get a new needle, follow the exact same technique where this goes in first and then you go right through here, okay? So that is basically the procedure for spinal and epidural block. Of course, we'll have another probably meeting, to maybe a Zoom class or something where we can talk about these blocks. I'll be happy to answer questions. If you have questions about them, write them down, and that way when we have that Zoom meeting as an entire class, we'll sit down, I can answer those for you. That way you don't forget what they are. And again, we'll have practice time for you guys to come in and practice this, and we'll go through it, you know, step by step, hands-on, all that kind of stuff, all right? So that's it for today. Thanks for your patience watching this video, and I hope it's been helpful to you.